54-year-old self-identified Caucasian man with a history of alcohol-induced liver cirrhosis presents to the emergency department with a 2-day history of progressive abdominal pain, distension, and low-grade fever. Okay, so it's important to note that this is this history of cirrhosis and this progressive abdominal pain, distension, and low-grade fever. He also reports a feeling of generalized weakness, but denies any episode of hematemesis, melena, or confusion. Okay, so that's important to note because if there was hematemesis from melena, you would be concerned for some kind of a bleed, specifically of esophageal varices in the setting of his cirrhosis. Furthermore, he has no recent history of instrumentation, prior surgeries, or specific skin infections. On physical exam, he appears acutely ill and uncomfortable. Temperature is 100.8, so he is febrile. Heart rate is 92, respiratory rate 16, and blood pressure is 108/64. Sclera icterus is noted bilaterally. The abdomen is markedly distended with visible collateral venous patterning, so markedly distended. Palpation demonstrates diffuse abdominal tenderness, mild rebound tenderness that is most pronounced in the lower quadrants. A distinct fluid wave and shifting dullness are also present. Neurological examination reveals no asterixis, and he is fully oriented to person, place, and time. Laboratory evaluation demonstrates a normal total serum leukocyte count of 12,500, elevated total bilirubin, which of the following is the most appropriate initial diagnostic study. So anytime you have a presentation of this patient who has a history of cirrhosis that's coming in with what seems like decompensated cirrhosis because of all the ascites and abdominal pain, your concern, especially with fever, should go right to a spontaneous bacterial peritonitis. So SBP should be the first thing you sort of want to rule out because it can be very life-threatening. And the way we do that is through a diagnostic paracentesis. And a diagnostic paracentesis should yield an absolute neutrophil count greater than 250 is most classically what you'll need to remember for these boards. And I'll write A and C. So the neutrophils in that fluid study should be above 250 for you to be able to diagnose it. And then the treatment ultimately is going to be ceftriaxone, which is a third-generation cephalosporin. And so these are the important things to note when you see a febrile patient, cirrhosis, abdominal pain, distension, ascites, fever, all these things, this will be your first line of thinking before anything else. So let's work through these answer choices. So A, abdominal CT scan with IV contrast. You would do this if you're concerned for some kind of an abscess, if you're concerned for some kind of a peritonitis through perforated viscus, or any of those reasons, but it would not help you make this diagnosis of SBP. Diagnostic paracentesis, so we've already talked about this. This would be the right answer, and you would look for those findings as I discussed. EGD assessment, again, this would be useful if you were concerned for hematemesis or melena, because then you'd be able to address the esophageal varices for a patient that has cirrhosis. But for the diagnosis of a SBP, this patient is otherwise, I think, stable from this concern for esophageal varices, so you can sort of save that step for later. Right upper quadrant ultrasound. This would be useful if you're worried about any kind of liver problem, or even just looking for the gallbladder to see if there's any stones, or assessing for portal venous thrombosis that can happen with cirrhosis. Again, in this setting with a patient that's febrile and presenting with ascites, our concern for evaluating those pathologies is a little bit less and comes maybe later down the line. Ruling out SBP would be the first step. And then lastly here, serum bacterial blood culture collection. You'd do if you're concerned for bacteremia or sepsis, something that can happen downstream of SBP, but it would not help you make the diagnosis of SBP. So again, that would be a step that you would maybe follow with later, but your first step here would be doing a diagnostic paracentesis to determine whether this patient needs to get treated for SBP or not. So for those reasons, B is the correct answer.